Okay. So thank you for joining Artist Senior Living, Assisting Hands Home Care, and Veteran Care Services for our webinar about understanding the invisible wounds of war as our veterans age. Our webinars are designed to provide caregivers with information they can use to keep themselves and their loved ones happy and at home. It is tough to accept our loved ones' behaviors and moods change as they age or illness takes hold. But it might not be that your loved one is just cranky or ornery. They might have a mental illness that is related to their military service that is presenting itself now. Addressing this issue is today's speaker, Dr. Heidi Kraft, the clinical director at San Diego-based Psych Armor Institute. Heidi received her PhD in clinical psychology from the UC San Diego SDSU Joint Doctoral Program in Clinical Psychology in 1996. She joined the Navy, thank you for your service, during her internship at Duke University Medical Center, and went on to serve as both a flight and clinical psychologist. Dr. Kraft left active duty in 2005 after 9 years in the Navy. She currently serves as Chief Clinical Officer at Psych Armor Institute, a national nonprofit that provides free online education for those who live with, care for, and work with military veterans. She is frequently invited to speak at conferences and panels on combat stress, stigma, and caring for the caregiver. Dr. Kraft is also a lecturer at San Diego State University, where she teaches stress, trauma, and the psychological experience of combat, as well as health psychology, abnormal psychology, and infant and child development. She's also an author and a mother of twins. Dr. Kraft will delve into what mental health distress signs to look for and how caregivers can cope with these changes in our aging veterans. Please ask any questions you'd like to Dr. Kraft or in the chat box, or raise your hand or unmute yourself. And I'm going to hand it over to Dr. Kraft now.
Great. Thank you so much, Vicki. It is really a pleasure to be with all of you today. As Vicki mentioned, I am a military veteran, 10 years in the Navy, including a combat deployment to Iraq, which was 16 years ago now. Sometimes that feels like yesterday, and sometimes it feels like a lifetime ago. But it certainly shaped me as a psychologist, as a mother, as a daughter, as a wife. I still, to this day, have perspective from that experience that has been very valuable to me, both clinically and personally. I think there's pieces of military service which are so unique, and the military culture is so unique. So those of you who are caring for a military veteran or know someone who is, know that probably firsthand, but many don't. I think there's a pretty big gap in our country of understanding of military culture and the way that it affects our lives and how we work, how we love, and how we age. And it's unique and it's life-changing. I think that I learned all of this a lot of it's come full circle, I guess, between the work of a clinical flight psychologist on active duty in a combat zone while my twins were at home with my Marine husband. And by the way, happy birthday to the Marines today. But it also has informed, that experience has informed the way I've taken care of patients since then, the way I've interacted with my children as they grew, the things that mattered and the things that didn't matter as much. It changes people, and it's okay for us to be changed and to pay attention to that change and embrace that change in the ones that we love. I come to you today with gratitude. Gratitude for you as caregivers, whether those are personal caregivers of someone you love or professional caregivers. You are among our country's true heroes. and those of us who have served and have gone on to age and or suffer some sort of wound that requires caregiving. I think I will speak on behalf of all of them to say that our caregivers are among our most important support systems. So I know caregiving is not easy, and I am grateful that you are in the roles that you are, and that that the people who you are caring for have you in their lives. This is a personal story for me, because after I left active duty, when I was deployed to Iraq, my twins were 15 months old, and my husband, who just left the Marine Corps, was at home with them. There's nothing about that story that makes sense for a Marine, that he didn't deploy and I did. But he needed help, and they were babies and he was working, and my parents came to stay with him the whole time I was deployed, and they helped him with the twins. My dad was a retired submarine officer in the Navy, a Naval Academy grad, and he knew what it meant to deploy. My mom had been a military spouse her whole life, and she knew what it meant to deploy and to have children at home. So I was very fortunate that my parents were able to support my family in that way when I was gone. My dad, he was one of a kind. He was a very special, different gentleman, a Southern gentleman who spent 20 years on active duty. And I got the feeling that he was probably one of those leaders that his sailors would have followed him anywhere. When my dad was 90, 2 years ago, we all got together for his 90th birthday, and he started to have neurological symptoms that were pretty scary. He started to kind of lose the ability to grasp his eating utensils. He started to lose the ability to move his feet, to get in and out of the chair. It was scary, and we went straight to the VA in San Diego. He was down with us in San Diego, and he was admitted, and later had not emergency, but urgent spinal surgery, which was a big deal for a 90-year-old. It was a risk. And he survived the surgery, but had a number of sequelae afterward. It was a long haul in the hospital. And when he was finally discharged to a nursing home, my mom needed help. And so there I was, a Navy veteran, psychologist, mother of, at that time, teenagers. And I was in a part-time caregiving role. And it was part-time. We had professional assistants. My mom was really doing it full-time, but even that experience really led me to a very unique understanding, I think, of the toll that caretaking takes and how much it takes from the caregiver to be able to do what you do. It's exhausting, it's rewarding, it's wonderful, it's isolating. There's many, many words that can be used to describe it, but I think my point is to say that I spent a little tiny window of time in your world, and I took care of an aging veteran for a little while. And up until the time that he left us, he died almost 2 years ago now. And I have a whole new empathy for the work that you do and how important it is. So thank you. Today, what I was asked to be here to join you with is to talk a little bit about some of the veterans that you might have a chance to come across, or those that you're caring for right now, may in fact be dealing with, as they age, kind of an interesting combination of some of the wounds that they may have experienced during military service. Now, many of you know, you see someone who's blind, who's walking with a service dog. You see someone with a prosthetic limb. you see someone who's been burned. These are wounds that we can take one look at the person and know that they're injured. There are other wounds that are not as easy to be able to tell. Maybe they look perfect on the outside. Maybe they have no visible wounds, but actually they're injured. And this is kind of a philosophy that maybe medicine started to pull together back some time ago, to actually call these wounds injuries rather than reactions or disorders, but more injuries, because they are in fact a result of the service. Could be a result of war. It could be a result of other experiences that happened while on active duty. There's lots of different ways that trauma can enter someone's life. We have, unfortunately, military sexual trauma, which certainly affects a lot of people. We have training accidents. We have the loss of comrades. We have long and difficult deployments away from family. We have a lot of unpredictability. And when those things kind of combine, sometimes we end up with exhaustion and guilt and shame and other things that come along with some of these experiences that can lead to these injuries, these wounds that are truly injuries. And just like any injury, they can be treated. So I think the point of this presentation is to go over a few of those invisible injuries in a way that I can maybe illuminate some of the symptoms that might be related to those injuries. Maybe talk a little bit about what this might look like as someone is aging and how important it is, excuse me, to bring these conversations to your doctor if you're going to doctor's appointments with your care recipient, so that the right treatment can be brought to the person that you're caring for. So let's start with post-traumatic stress disorder. This is kind of the one that we talk about the most. It's caused by trauma. Pure and simple. It has to include a traumatic experience. Makes it different than anything else in our diagnostic manual. Traumas can be from anything. They can be all the way from car accidents to natural disasters to personal assault, to childhood trauma, to war. And our veterans could have a number of these traumatic experiences, and those traumatic experiences can actually be cumulative. So I know that when I take care of people after war trauma, sometimes when they come to talk to me and we get a full background, a full eval, I find out that these folks had experienced significant child abuse. And those two traumas then start to sort of build on each other. The bottom line is that regardless of what that situation is, traumas shatter beliefs. And so the person's entire belief system can be affected. Memories can be distorted. They often are. Belief systems can change so that the person starts to try to accommodate for what happened, or assimilate new life their new life into what happened so that it makes sense. But this can cause problems. It can cause symptoms in the person's daily life. So we have 4 symptom categories that people might experience symptoms of PTSD. And they include re-experiencing the event. This can show up as flashbacks, where the person actually feels like he or she is back in the event. It could be intrusive memories, and it can be nightmares, traumatic nightmares. People try to avoid things that remind them of the trauma. So many times we see with our combat trauma veterans, we see them feeling like they're avoiding crowded restaurants and movie theaters and big stores like Target or Costco, where they get the feeling of being back in that traumatic experience, being stuck and not being able to escape, or feeling like there's people behind them. We also see changes in reactivity, where this is where kind of a classic loud noise causes an exaggerated startle response. People tend to feel really irritable, and a lot of anxiety comes along with this. And then changes in mood and thinking. This can look like depression. It can look like anxiety. There are, as I said, distorted memories of the event. So people feel a lot of guilt and shame. They blame themselves. There can be really kind of distorted ways of thinking about what happened. So at home, this might look like pretty significant sleep disturbance. It can look very much like depression, and many times those two actually are comorbid together. They overlap. We can see people have memory and attention, concentration problems, and unfortunately, sometimes people self-medicate. They drink or use drugs to try to numb some of the pain that comes with PTSD. As people age, as veterans age, the key with PTSD and aging is if it's not treated, these symptoms continue to build on themselves and become more and more entrenched in daily life for the person. As we go through more and more years of a distorted memory that causes us to change our behaviors and isolate and not do the things that we want to do with our families. And we start to have these kinds of breakdowns in the way that we function. This gets more and more entrenched with age. So as these current wars started back in 2000, the VA saw a number of veterans from the Vietnam and Korean wars finally coming for treatment because they were being triggered by imagery of the current war. And they were encouraged at that point to start to come for treatment. But this was 40 years for some of them, 50 years for others of untreated symptoms. So there was a lot that needed to then be unfolded in order to start to get to the treatment of PTSD. Treatment does work. We're going to be talking about that a little bit later, but treatment is very effective for PTSD. Age just complicates it if it hasn't been treated. Any questions on the symptoms of PTSD before I move on? Or comments? Another of our invisible wounds is traumatic brain injury. Unfortunately, this has become kind of the signature wound of the wars in Iraq and Afghanistan because of the use of improvised explosive devices, or sort of buried bombs, if you will, that have been used as a weapon. We've had a number of people who served in those wars experience TBI, or traumatic brain injury. Basically, what we're talking about here is damage to the brain. The vast majority of TBIs are mild, and they're called concussions. They can be caused by impact, in other words, falling and hitting the head, or having something hit the head, or being knocked off your feet and hitting your head. It can be caused by penetration, a penetrating injury of shrapnel or a bullet, or it can be a wave injury, which we found is very significant in our current veterans, in that even if they didn't hit their heads, proximity to the blast caused actual impact waves to move through their brains. And if you think about a brain, it's really soft and squishy inside of a hard case that's protecting it. But if there's an impact wave or anything that moves the brain around, it can get bruised and bang against that skull, and it can start to bleed or have inflammation that causes problems. The symptoms of TBI, and again, I'm talking about mild TBI here, more moderate and severe TBI obviously leads to great impairment and is a kind of a different talk. But for today's talk, we'll talk about the majority of TBI, which is mild. And the symptoms can be really varied person to person, and they can resolve by themselves in just a couple of weeks, or they can linger for a while. And many people do have them linger, especially if there's been more than one TBI, which we do see in our military veterans, that they were exposed to blasts over and over and over again. In fact, sometimes I would screen for TBI when I'm meeting with one of my active duty Marine patients. And so, did you ever have a TBI? I mean, no, ma'am. Were you ever anywhere close to a blast? And they look at me and say, well, of course. Well, how often? Every day, you know? So we're talking about this cumulative effect that really can cause significant problems. The symptoms can include fatigue, headaches, dizziness, difficulty with memory, difficulty with concentration, mood changes like depression or anxiety, ringing in the ears or tinnitus, and lots of disturbance with sleep. You might have already started to notice that some of those symptoms look familiar. We just went over them. We're going to be talking about that. Any questions about TBI before I move on?
Now, Dr. Kraft, even though a TBI can heal, you know, you said from days to weeks, can you have lasting effects throughout the rest of your life?
Yes, you can. So it all depends on how much damage is done to the brain and where that damage is, right? So it is 100% dependent on that. For many people, mild TBI does cause symptoms for a few weeks, and the brain develops compensatory pathways around the injury, and the injury is very mild, and they recover. Many of us have had concussions. We've had that experience. As that injury gets just a little more serious, or it affects a piece or part of the brain that is directly related to something like headaches, or something like sensitivity to light, or something like dizziness or ringing in the ears, those kinds of symptoms can continue, and for many they do, for years, or they go on sort of indefinitely. And really treatment for that goes into managing symptoms and accommodating for them so that quality of life can be as high as it can.
Okay. There's a question about, is dementia a greater risk if someone has had, they are asking about severe TBI, but with any brain injury, is that tied to dementia risk?
It can be. Again, it depends on the part of the brain. So really good question. And there is some data that seems to connect those, but it depends on the part of the brain where the injury occurred. So it's a more complicated neurological answer.
Okay, so there can be numerous injuries to various parts of the brain.
Sure, absolutely.
Okay.
Yep. Yeah, and again, every time you have a TBI, you are increasing your risk that those symptoms get worse. So it's called second impact syndrome. You are at great risk within the first week or two after a TBI if you get another one. And that's the problem with the military situation, is that many times people are knocked off their feet, they see stars, they feel disoriented after being near an explosion. They stand up, they go back to work, no one saw it happen. No one knows it happened. They don't even know it happened. Maybe they lost consciousness, maybe they didn't. If I ask one of my Marines, did you lose consciousness? And they say, I don't know. That's not the answer I'm looking for, right? That's a concern. If you're not sure if you lost consciousness, then you probably did, right? So it can be very disorienting, and that worries me then when I hear that, because I think if they've been exposed to blasts all the time, over and over and over and over again, we're talking about the possibility of some pretty significant lasting symptoms.
Okay. Thank you.
Another of our invisible wounds that we talk about after military service is depression. And many of you are very familiar with depression, but it's important to review it, because I think we forget sometimes that this can actually be an injury that occurs because we've had a very stressful time. We've lived through something extremely stressful. One of the theories of the development of depression is called the learned helplessness theory. And it means that as very difficult things have happened around you, you keep trying and you keep trying and you keep trying, and these things keep happening, and eventually depression sets in. Sometimes I feel like people who have lived through a lot of trauma, and for whom this story feels very heavy, that the situation has been really, really difficult and challenging, that sometimes depression is the result. Now, depression can also happen without stressful external relationship problems or other stressful events. It can be, the etiology of depression can be chemical, it can be biological, it can have nothing to do with outside events. But when we're talking about this, an invisible wound of military service, we're usually talking about a result of external, extremely stressful events, maybe in combination with genetics. Depression is extremely common, and it does not discriminate between genders, ethnicities, social economic status, military rank, none of the above. One thing that is very important to understand is that depression is not a normal sign of aging. We should not expect our aging population to look depressed because they are aging. That is not normal. Depression causes impairment in life, and if it's starting to cause impairment in an aging veteran that you care about, this is something to talk to a doctor about. It is not a normal sign of aging. So I hope if one thing kind of stays with you through this presentation, it's this one. Symptoms of depression can include depressed mood and loss of pleasure. Those are the two biggies. Things that used to be fun are not fun anymore. It's called anhedonia, and it's one of the hallmark symptoms of depression. Other symptoms can be lack of energy, lack of motivation, kind of either like feeling like the person is moving in slow motion. Things kind of really slow down. Appetite changes, and this can include losing or gaining weight without meaning to. Sleep changes, either sleeping not enough or way too much. Guilt, trouble concentrating, and thoughts of suicide, which of course are medical emergencies. All of these symptoms, any of these symptoms, should be symptoms that you take to your care recipient's doctor if they are showing up in your person's life. Questions on depression? A final invisible wound, if you will, a result of some of the stressors of military service can be substance use disorder. For veterans, this is a culturally acceptable way to manage grief, guilt. It can be a source of joy and celebration as well, but in the military, it's culturally accepted. And so it is a socially acceptable, legal way. I'm talking about drinking right now and marijuana use in some places. It's a legal alternative to seeking help. Our veterans don't want to seek help. They do not want to admit that they need help. This is a cultural phenomenon of ours. So it's a way to kind of numb those feelings, a way to get through it in the short term. Of course, most of you know that drowning your sorrows doesn't work very well because sorrows are great swimmers. Well, it turns out that so is trauma. It's obviously not a super effective coping mechanism, but it is one that a lot of people use. It's very, very common. It also can be used for self-medication of pain or depressive symptoms, that the person is trying to take care of those symptoms on his or her own without having to seek medical help. A couple things to know about substance use disorder. This is new in our diagnostic manual. Every substance has its own disorder. So you could have cannabis use disorder, cocaine use disorder, alcohol use disorder. The symptoms are measured over the last year, and how many symptoms you have over that year defines how severe the substance use disorder is. So we'll either say mild, moderate, or severe. Symptoms include withdrawing from the substance. So the symptoms that a person feels as the substance leaves the body. From alcohol, this is a hangover. In the more mild term, of course, alcohol withdrawal. If a person has been drinking a lot more or has ingested a lot, alcohol withdrawal can be deadly. Tolerance is the building up of needing more of the substance to get the same effect. So maybe where 2 beers gave you that kind of socially inhibited, relaxed feeling, as you do it more and more, now you need 3, then maybe later you need 4. That's tolerance. Use despite problems. using more than you meant to use. A lot of times people will say, I went to a party planning to be the designated driver, and then I started drinking. Desiring to make attempts to quit, a desire to quit or trying to quit. Craving the substance, this can be psychological or physical. People say sometimes they feel it in their bones. Use leading to dangerous situations like driving while intoxicated, and a reduction in the activities that used to matter to the person. So we look at all these symptoms and we look at how much they have occurred in the last year. The more of those symptoms that have occurred for a person in that year, that's dependent then on how that diagnosis is made, mild, moderate, or severe. Questions about substance use disorder at the moment?
I actually have a question about something general you just said that struck me, but you might address it later. You said vets don't seek help. It's a cultural phenomenon among the veteran community. Is there a way to break through that and get them to turn the corner, to admit they might need help with either a brain injury, depression, substance use?
Yeah, I think for veterans, it's about stigma. So they have in their culture a great stigma against asking for help. It's a other focused culture. They're all about helping other people. And so very challenging to get veterans and their families, by the way, families too, to get them to admit that they're not going to be able to handle this on their own, that help is actually needed, and that help is okay, that seeking help is okay. So there's been a number of attempts over the last 20 years to try to reduce that stigma in the active duty forces, and hoping that that then trickles to the veteran community. Basically saying it's okay if you're not okay. We're not going to throw you away. If you need mental health support to get through this, that we'll get you back. We want you back stronger, and that treatment is okay. So we're getting there. It's slow going, but we are getting there. I think that for each of us, knowing a little bit about the military culture is a huge first step. Knowing the questions to ask so you can engage with a veteran, that person will open up a little bit and trust you. So PsychArmor has a great course called 15 Things Veterans Want You to Know. It's super short, it's easy and quick to take. And it talks through things like the fact that we're not all soldiers, right? We serve in different branches, and we're very proud of those branches. And so asking a veteran, when you know someone has served, just asking what branch did you serve in, you get to skip about 10 steps of credibility at that point. That shows that you know that the branches are different, and that which branch the person was in mattered to the person. And then the conversation can start. And I think that if we can have those conversations, Vicki, we are more likely to be able then to validate, this is okay. It's okay that you're struggling with this. There's help, it works. Let's do that. Let's get some help for you. And I think developing that kind of trust is important first, probably vital first. It's not gonna happen without it.
I just want to bounce off of what Vicki said. She actually stole my question, but through osmosis. But just to follow up on that, and I'm not even sure if you can answer this. Is it a stigma that's created within the military? I know we see it a lot with the police. You know, the minute they say, I need help, then they're under scrutiny by captains and so forth. And then the minute they say they're depressed, their guns are temporarily removed. So is it a stigma created within inside the military?
Yes.
Are they able then to seek outside help so that they then don't seek help within that confinement, if you will?
Yeah, there's I think a lot of people that do. Yeah, I think there's a number of places. Actually, the military set up an outside help network specifically to have people be able to get help. It's called Military One Source. It's free for active duty, and it's not connected at all to their record. Now, they're limited with what they can treat. But I think for a lot of just getting through stressful situations, it's a really good alternative. And my understanding is it has been very well used.
So I have one other question and then I'm going to be quiet. When they come back from a tour and they're debriefed, at that point, do they go through a short like psychological evaluation to see if there's any, you know, any type of something that would signal, you know, for these veterans to go get help?
Yes, so there's a screening that happens on the way home, basically. And my understanding, at least when I was going through it, and it's evolving, I think, but it was basically just a screening, like you answered questions, but everyone just answered no to everything.
Right, you have to be voluntarily answering the questions. Yeah, right. For sure. Right. Thank you.
Yeah, unfortunately. And that may be changing. I think they've been trying to figure out ways to, you know, do sort of a group debrief and then have people actually meet individually with someone. It's just, that slows things down, you know, to get people home. But they're working on it. They're working on different screenings that it's gotten much more evolved since I went through it. And I think there's a real effort to get that system in place so that they can find out when a deployment has led to symptoms in somebody and get them help right away. That's, of course, the best case scenario.
Thank you.
Any other questions? So let's talk about the effect of these experiences on caregivers and families. For post-traumatic stress disorder, as I said, there's sleep disturbance, which can be very marked, and pretty horrible nightmares that can come along with PTSD. For many people who sleep in the same room as a person with PTSD who's having nightmares, this can be very scary. And sometimes I've had a couple of patients say that they woke up with their hands around their wife's neck, you know, sort of part of the dream. So it can actually put the caregiver or the family member in danger. So I have a number of my patients that while they were in treatment for PTSD, they actually slept in different rooms from their spouses so that they wouldn't have to worry about that piece. But the sleep disturbance can cause significant anxiety for family members. It's tough while that person is going through sort of the trauma playing itself out through their dreams. This can be a rough experience for family members. So I always tell family members and caregivers, protect yourself here. You need your sleep. So set up the situation where you can get the sleep you need while your loved one is in treatment. The anxiety and the agitation, the jumpiness and the quick anger that people can feel while they are dealing with PTSD can directly affect a family. I've had a number of my patients say that their children, if they startled them, they would turn around and kind of, you know, like turn on them basically. You don't want to startle someone with PTSD. And children, it's hard for them to know that. Noise, a lot of noise and chaos in a house can cause a person with PTSD to really feel anxious and agitated. And you can see anger come out towards the family because of that. I've always tried to counsel my families, this isn't your fault. You didn't do anything wrong. It's just the way the PTSD is playing out. Memory difficulties can be very significant. A lot of times there have to be accommodations that are made to be able to help people remember. I talked about the avoidance of reminders and triggers that come along with PTSD. This can affect the whole family because a lot of times the person doesn't want to go to a restaurant, so the family just doesn't go out or they don't go to the movies. The veteran can't help with going to Costco because he or she can't tolerate being in Costco. So these are the things that will get better with treatment. But in the meantime, I think it's really helpful for families to know that these symptoms are not, that's not your veteran, right? That's not, your veteran isn't yelling at you for being too loud, or your veteran isn't avoiding going out to dinner because that's what he or she wants to do. The person is really struggling with these symptoms, and sort of being able to give those symptoms to PTSD, to knowing what is the disorder and what will get better with treatment seems to be very helpful for families. Questions on that? For traumatic brain injury, a lot of these are similar in that TBI can also cause sleep disturbance and nightmares. It can cause changing and kind of emotional reactivity. So the person may suddenly seem very angry, very upset, very anxious. Unfortunately, with TBI, sometimes we see disorientation or confusion, kind of changes in the way the person thinks. And that's really hard sometimes for families to deal with because they don't know whether they're looking at their person who suddenly is thinking differently about things. That's pretty upsetting sometimes to watch someone look so different, especially the personality changes that can come with TBI. A person that had been very sweet can suddenly be really intense. A person that had been a real go-getter can suddenly look very meek and unmotivated. And it's hard for families and caregivers to know what to do with that. With memory is a big one with TBI, so it is important for families to work with their care team, with the cognitive rehab team, with the physicians, with the neurologists and neuropsychologists to figure out the very best way to set up the veteran for success and to set up the family for success. Different reminders, different calendars, so that the memory that sometimes is very affected and that memory stays affected, we can work around it. With TBI, sometimes people isolate. It's heartbreaking, but I took care of a Marine who told me that he had a TBI, and he told me that he went to a party and he overheard these three people talking about cars. They had been working on engines of cars, and he grew up working on engines of cars with his dad, and he knew exactly what they were talking about. And he didn't know them, so he thought this was a really easy way to jump into their conversation, introduce himself, and say, I did this too, I understand. And he got into their circle and introduced himself, and then he went to try to tell them that he knew what they were talking about this carburetor or this whatever it was they were discussing. And he had worked on it too, and he had a thought of what they were talking about, and he knew what he wanted to say, but he couldn't make the words come out in the sentence that he wanted to say. And it was heartbreaking to hear him tell me this. It's probably a combination of some anxiety that kind of interfered there, but that's a direct brain injury experience, and it's heartbreaking. And he found himself isolating more and more because of that. So we can see depression immediately kind of crossing over into this effect that families have to deal with. Questions or thoughts on this? For depression, many of you probably know this, but the effect on families and caregivers is pretty significant, because when people are dealing with depression, they reduce their activities. They stop doing things that used to matter to them, and this can directly affect their families. Their families might have been very involved in those activities. Men who feel depression can often be very angry. That can be the way their symptoms show up. Women can be very emotionally labile, or they can cry easily, they can yell easily, they sort of can have emotional outbursts when they're feeling depressed. Sleep disturbance, of course, is very significant in depression, either not being able to sleep or sleeping too much. Again, direct effect on the families here. Negative thoughts about themselves, about each other, about the future. These can directly cause families to feel that what they're trying to offer up as a possible solution, the veteran keeps kind of, no, throwing it down. That happened with my dad as he was moving through my caregiving experience. He just got kind of more and more negative and showed kind of a lack of hope, which was really hard for me to deal with. I wanted him to stay motivated and to stay hopeful about his rehab and to think that he could get better. And the depression got worse and worse. And it was really tough on me as a caregiver to have to watch that and to realize that everything I tried got shot down. We can see people self-medicate when they're depressed, start drinking more, start smoking, start using marijuana or other drugs to try to numb the pain. It doesn't work. It makes it worse. It's a central nervous system depressant, alcohol. So we're compounding that effect. And then we are, of course, very concerned about people who get very depressed, starting to think about suicide. It's a medical emergency, and it's okay to ask directly if you're concerned about someone. Are you thinking about killing yourself? If the answer is yes, you stay with the person and get them to professional help. Again, remember, for aging veterans, depression is not a normal part of aging. If any of these symptoms are affecting you and your family, it's time to talk to your veterans doctor. For substance use disorder, a lot of effects here, right? The person is changing his or her life to use the substance and often feels very guilty about that, can deny it, can lie. The family can feel like the person is choosing the drug over the family. And this can cause a lot of kind of emotional upheaval and chaos in the family. Of course, when you're using, a lot of times your personality looks different. And that can be really difficult to deal with, especially for caregivers and children. There's a real worry that the person will drink and drive or use and drive or be in a dangerous situation where he or she might get hurt. And this is kind of a constant worry. If you're concerned that a person that you're caring for is using a substance too much and is starting to depend on that substance, and that substance is interfering with your life, this is another good conversation to have with your care recipient's doctor. Especially if that substance is opioids. We know that there's another epidemic in our country, and that's opioid overdose. Very, very important, if the person you're caring for is using opioids, to be watching for some of those other signs that this use might be risky. If the person is also using alcohol or benzodiazepines, that makes them very high risk. If they're using high dose opioids for pain control, that makes them high risk. So a couple of kind of key conversations to have with your care recipient's doctor. We have naloxone now, which is a opioid antagonist. It's given in a nasal spray, like a Flonase, like a allergy medicine. Or there's a few other ways to give it, but the most common is the nasal spray. And if family members are worried about opioid overdose, it's very important to talk to your doctor about having naloxone in your house, because all you have to do is give a couple squirts of naloxone and the overdose is over. It will stop the effect of the opioid. It's remarkably effective at saving lives. Questions on any of this? So one thing you might have noticed as I went through the symptoms and the effects on the families is the overlap, right? A lot of these symptoms were the same. A lot of the effects on the family were the same. So where we struggle sometimes clinically is figuring out what we're looking at. What is first? What is most important? What should we treat first, right? All of those things. And so it is important to bring the symptoms that you see, now that you've seen some of them, if any of those are occurring with the person you're caring for, or in your family, if you're feeling these effects, this is important to have a conversation. And then let the clinicians try to figure out what they're looking at. Sometimes it's hard. Sometimes there's multiple things happening at once. Sometimes people fit criteria for all 4 of these that I've gone over with you. So, and sometimes they don't. Sometimes what we're actually looking at is depression, or what we're actually looking at is PTSD, but it has symptoms of depression. But the person doesn't have depression. They just have some of the symptoms, but because of the trauma. So it's very important to know what we need to treat first, and how those things are going to work together. So the overlap is a challenge. In your case, the symptoms are the most important part. If your veteran is experiencing symptoms, or if your family is being affected by these, that's still very worth talking to your doctor.
Okay.
So, oh, yes.
I just want to interrupt you because Shira had a question here, and I'm hoping she can jump on and clarify. Is there a specific age group that you see this is more common in? Shira, I'm not sure what you're referring to.
I was just wondering, when you were talking about the use of narcotics, if you found that there was a specific age group that it was more common in, if you see that there's a problem, you know, with seniors, or if it's more of the younger generation of veterans.
Unfortunately, the opioid epidemic is across all ages. Our younger generation of veterans have been prescribed opioids for wounds, for pain control. That's what they're prescribed for, right? Pain control, and they're very, very good pain control. That's what they do. So people are prescribed opioids to help with pain after surgery, after an injury, and they are just unfortunately extraordinarily addictive. And so people very quickly develop a physical tolerance to them, and it's very difficult to stop. And it starts to cause all sorts of problems because they need to get that prescription somewhere. Unfortunately, this is something we see in our younger generation as well as our older generation. I know that with our older veterans, at least when I was sort of going through this with my dad, there was definitely a real attempt on the part of the VA staff to really limit the amount of opioids that were used, which I really appreciated. They were trying to they were realizing how much this could affect someone who was older and how dangerous that could be. And so there was I could see the clinical staff working hard to balance what they gave him after surgery for pain and very quickly trying to move that to something different that wasn't an opioid. There was a push to try to do that. But unfortunately, we do still see overdoses in our older population as well. Okay, so to support people, veterans, everyone who has these invisible wounds, it's important to be informed. And so now you are. You know some of the symptoms, knowing what's available to you. And certainly, I think being involved in the organizations that you are is a start. And find those networks that are supportive for you as well. Break the silence about this. If you see symptoms in the person that you're caring about, this is an okay conversation to have. It is okay for that person not to be okay, and it's okay for you to talk to that person about it. Be willing to go on the journey with him or her. Sometimes part of these symptoms are wrapped into a story. It's okay to hear the story and to go along that journey with the person. I think, again, that bridges that credibility so that the person might be more willing to accept help if he or she knows that you understand and that you accept and that you don't judge. Really encourage treatment for all four of these. It works. We have evidence-based therapy for PTSD and for depression, which have decades and decades of research behind them that show that they work. Both of them have about 2 to 3 month protocols in therapy it's not easy work, don't get me wrong, it's hard work. The veterans have to work hard, but it works. And sometimes it works even without medication. I certainly can, if my patients want to do an antidepressant at the same time to kind of reduce their anxiety, help them sleep, it's very important to get sleep regulated. Same with depression. You could do one of the newer antidepressants to help as you move through the treatment, but you don't have to. They work even without the medication. For TBI, cognitive rehab is really, really helpful. This is sort of an all-encompassing kind of look at the life of the person with the TBI and how best to accommodate those things, those deficits that might be happening so that the person can live the highest quality of life possible. For substance use disorder, there's a lot of different types of treatment, everything from community-based 12-step models all the way to inpatient detox and everything in between. But people can and do stop using substances and stop having those substances have that effect in their lives. So treatment works. So all four of these have treatments that work. And that's helpful to be able to encourage the person you're caring for to say, there actually is something you can do about this. There is hope. It works. So really important to seek that. and engage with that treatment. That's sort of what I have. We have some resources here that Vicki put on a last slide, but what other questions can I answer for the group, or what other comments do you have? I'd love to hear them.
Anybody have anything?
Job. Oops. I was going to say, I think you've done an excellent job of outlining what we should be looking for. And I really appreciate your time because I thought it was very beneficial.
Oh, wonderful. I'm so glad to hear that.
Yes, this was a great presentation, Dr. Kraft. Thank you so much.
Thank you. I very much appreciate that. That means a lot to me. Any other questions from anybody?
Okay, if I don't hear any questions, we'll wrap it up for today. This session was recorded, so I will get that up on YouTube as soon as humanly possible and share the link with everybody. Feel free to share it with anybody you think could use this information. So thank you so much, Dr. Kraft. We appreciate information so much, and I know it will help so many people.
Wonderful. I appreciate it. And thank you very much for the invitation.
Absolutely. Thank you so very, very much. Thank you.
Thank you, everyone. Have a good afternoon, everyone.
Have a good afternoon.
Bye, everyone.
Okay, bye-bye.
Hi, thank you so much. It was a great presentation, and I look forward to sharing the information with all of our veterans that we work with.
I appreciate that, Shira. Thank you. And thanks for everything you do as well.
Thank you. Have a good day.
Thanks.
Bye-bye.
Good job, Vicki.
Thank you, Eric. We'll talk to you soon.